This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the University of Oklahoma, published in Acta Neurochirurgica in 2026. It's a quantitative cadaveric comparative study titled Microscopic Transorbital versus Mini-pterional Approach to MCA Bifurcation Aneurysms, a quantitative cadaveric comparative study with surgical implications.
This is a timely topic, Alara. We've seen the keyhole revolution for a while now. While the peritoneal approach, and more recently the mini-pterional, is the workhorse for middle cerebral artery aneurysms, the transorbital approach, or TOA, is pushing the boundaries of what we can do through even smaller corridors.
Exactly. MCA bifurcation aneurysms account for about 20% of all intracranial aneurysms. The standard of care demands early M1 segment control and safe dissection around M2 branches and perforators. The question this study asks is, can a microscopic transorbital approach actually compete with the mini-pterional in terms of surgical geometry?
And for our listeners, it's important to clarify the specific TOA variant they used here. We aren't talking about the purely endoscopic transorbital route that's often used for the cavernous sinus.
Right. The authors, Golsinna and colleagues, used a microscopic eyelid transorbital approach with a modified one-piece orbitozygomatic craniotomy. They call it the lateral TOA. It involves an incision hidden in the eyelid crease, a partial orbital rim disconnection, and drilling of the greater sphenoid wing. It's distinct from the endoscopic-only routes.
Let's dive into the methodology. They used 5 lightly embalmed human cadaveric heads, so 10 sides total, injected with red and blue silicone. I like that they used lightly embalmed specimens. It better simulates tissue pliability, especially when you're retracting the globe.
Exactly. They compared the mini-pterional, MP, on one side and the TOA on the other, using neuronavigation to measure specific parameters: access depth, the M1 angle, which is the access angle to the first segment of the MCA, and the horizontal and vertical angles of attack to the MCA bifurcation.
Let's look at the results. What was the working distance like? Usually, people assume the transorbital route is much deeper and more restricted.
Surprisingly, the working distance was quite similar between the two. For the MP approach, it was 26.9 plus or minus 7.48 millimeters, and for the TOA, it was 31.0 plus or minus 7.49 millimeters. Statistically, that's a non-significant difference with a p-value of 0.24, so the reach required for the instruments is essentially the same.
That's interesting. It suggests that the perceived depth of the transorbital approach isn't a mechanical barrier. But what about the elbow room, the angles of attack?
That's where we see the divergence. The MP approach offered a significantly wider vertical angle of attack, 86.1 degrees compared to only 45.3 degrees in the TOA. That's a massive difference, nearly double the vertical maneuverability for the mini-pterional.
That makes intuitive sense. In the transorbital approach, your superior and inferior movements are physically constrained by the orbital roof and the floor of the surgical corridor. You're working through a tighter vertical slit.
Exactly. The study notes that the corridor is constrained medially by the globe, which restricts the maneuverability of instruments. However, if we look at the horizontal angle, side-to-side movement, the approaches were comparable. The MP was 25 degrees and the TOA was actually slightly wider at 33.6 degrees, though not statistically significant.
So if you're choosing the transorbital route, you have to be comfortable with a flatter, more horizontal working plane. But let's talk about the most critical part of an MCA aneurysm clipping, proximal control. How did the M1 angle compare?
This was perhaps the most significant finding of the study. The TOA approach demonstrated a significantly more perpendicular M1 angle, 54.3 degrees versus 32.7 degrees for the mini-pterional.
A more perpendicular angle to the M1. Why is that anatomically favorable?
It means the TOA gives you a more direct, straight-on view of the M1 segment. In a mini-pterional, you're often looking more down the barrel or at an oblique angle to the M1. Having a nearly 55-degree angle of access to that proximal segment could be a major advantage for placing a temporary clip, or for visualizing the perforators arising from the back of the M1.
That's a powerful argument for the TOA in selected cases. If the aneurysm is oriented in a way where proximal control is the primary concern, that perpendicularity is a gift. But we have to balance that against the loss of vertical freedom you mentioned earlier.
True. The authors emphasize that while the TOA offers these unique exposure characteristics, the mini-pterional remains the gold standard for a reason. It provides broader exposure and better overall maneuverability.
Let's talk about the surgical real estate. When they performed the TOA, they did a one-piece modified orbitozygomatic craniotomy. That's more extensive than a simple keyhole.
It is. They explain that this modified OZ helps enhance the working corridor and degrees of freedom by extending the craniotomy and drilling the greater sphenoid wing. Even with that extra drilling, though, the globe remains the limiting factor. You have to be very careful with retraction.
Right. They use lightly embalmed cadavers, but in a living patient, the globe doesn't like being pushed on for 3 hours. There's the risk of bradycardia from the trigeminal cardiac reflex, or even retinal ischemia if the pressure is too high.
The paper does mention that. They suggest that the TOA's application to vascular pathology remains technically demanding and limited, but they also point out the cosmetic advantage. The incision is completely hidden in the eyelid crease, and there's minimal tissue disruption compared to even a mini-pterional, which still requires some temporal muscle dissection.
For a resident or a fellow listening to this, what are the surgical implications the authors want us to take away?
I think the takeaway is that the microscopic TOA is a viable alternative for MCA bifurcation aneurysms, but only if you select the patient based on the aneurysm's geometry. If the aneurysm requires a lot of vertical manipulation, say it's a very high-riding or low-riding bifurcation, the TOA might frustrate you because of that 45-degree vertical limit.
But if it's a standard bifurcation where M1 control is the bottleneck, the TOA gives you that beautiful perpendicular axis.
Exactly. The study provides evidence-based guidance. It defines the geometric differences. Instead of just saying it's a smaller hole, we now know exactly how much smaller the vertical angle is and how much better the M1 angle is.
It's interesting how neurosurgery is evolving toward these hidden corridors. We used to think the mini-pterional was minimal compared to the old large flaps. Now we're looking at an eyelid crease. Did the authors mention any specific limitations of their study?
The usual cadaveric limitations, the absence of brain pulsation and blood flow, and the fact that 5 specimens is a small sample size. However, the use of neuronavigation to get quantitative data, rather than just the view looked good, really strengthens their conclusions.
I also noted they used the Wilcoxon rank sum test for their statistics, with a significance threshold of p less than 0.05. It's a robust way to look at this kind of small sample comparative data.
One final point the paper makes is about the microscopic nature of the approach. Most of the recent literature on transorbital routes focuses on the endoscope. This study proves that the microscope, which most vascular neurosurgeons are more comfortable with for clipping, is perfectly compatible with the transorbital corridor.
That's a great point. You don't have to switch to sticks and a 2D monitor to go transorbital. You can keep your 3D visualization and your familiar microsurgical instruments.
So in summary, the working distance is nearly the same as a mini-pterional. You lose about half your vertical range of motion, but you gain a significantly better angle for proximal M1 control.
It's about having more tools in the toolkit. For the right patient, perhaps one very concerned about the cosmetic outcome, or one with a specific M1, M2 anatomy, the transorbital approach is no longer just a theoretical, cool trick. It's a geometrically sound option.
Well said, Dr. Aris. This study really helps bridge the gap between keyhole enthusiasm and anatomical reality.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
We'll link the full Acta Neurochirurgica paper in the show notes. See you next time.